If you don't know about Regina, I think most of the people that we work with are pretty familiar with you because of the history you've had in recovery. But Regina LaBelle is a national recognized leader in addiction policy. She served as acting director of the White House Office of National Drug Control Policy, which is ONDCP, during the Biden administration. Regina also served as an appointee in the Obama administration, where she oversaw the nation's, excuse me, response to the opioid crisis or epidemic at ONDCP. Regina is a founder and director of the Center of Addiction and Public Policy at the O'Neill Institute at Georgetown Law. She also founded, directs, and is professor at the Master of Science in Addiction Policy and Practice program in Georgetown School of Health. The unique one-year program seeks to build an addiction policy field that is rooted in science and evidence and driven by compassion. Thank you again for being here. We're going to let you is there anything you wanted to add? Okay, so we're going to let Regina share her screen.
Good. Thanks. All right. Thank you so much. And I'm really glad to be here. And I look forward to speaking with you today. If I can get my thing working. Hold on. Okay, let me start from the beginning. Okay, so what I'm going to talk about today is, and actually, you know, I gave a warning that I was going to have to update these probably every day, and there was new information that came out just last week that allowed me to give you kind of the latest information on what's happening on the federal level. That's really what I'm going to focus on today. And I'll look at kind of the structural changes that have occurred, some of the financing changes, and then finally we'll close out with some actions that can be taken right now to impact some of the latest rulemaking that has been issued, and also funding. So as was mentioned, I wear two hats. I'm at Georgetown University. Our Addiction and Public Policy Initiative at the O'Neill Institute. There we operate at the intersection of public health and the law to advance evidence-based practices and improve outcomes for people with substance use disorder or who have otherwise been impacted by addiction. And then secondly, this Master of Science program in addiction policy and practice, we have our 5th cohort right now. They are ready. We have our last class with them. I can't believe it's been a year. Our last class is this coming Friday. And our students come from a number of backgrounds. Many of them are in recovery, but many have otherwise been affected by substance use disorder or are just people who really care about this issue. And they've gone on to work in a variety of areas of addiction policy. From actually, a few had worked on the Trump transition team, have worked in the Biden White House. Others work in the Maryland state government, Indiana state government, DC state government, Oregon, so across the country. And really the purpose of this program is for people to really hit the ground running so that we're not having to wait a few years for someone to understand what best practices are. And they learn from some of the, some leaders, many of whom you have probably are aware of, Dr. Wilson Compton, Dr. Chris Jones. And so it's a great group of people. And this new crop will be looking for positions. So if any of you have openings, you should be in contact with me. So I'm sure many of you have heard the issue of substance use disorder being described as a niche issue. And I think there are, certainly that's understandable, but there are many reasons why this is not a niche issue. This is an issue that impacts 48.7 million Americans had a substance use disorder, according to the National Survey on Drug Use and Health in 2023. And only about 25% of people with a substance use disorder received any treatment. 42% of Americans know someone who has died of an overdose. More than 300,000 children lost a parent to overdose in a 10-year period. And 12% of children live in households with at least one parent with an untreated substance use disorder. Now, the National Institutes of Health estimates the economic cost of substance use disorder is more than $700 billion a year. So I firmly believe this is not a niche issue. This is a critically important public health issue that demands the highest level of attention from policymakers and from our communities. And I want to talk today, obviously, I'm going to talk about the federal level and how the federal response to substance use disorder has been impacted over the last couple of years. So first of all, and I'll go over this in a little bit, we've seen SAMHSA budget cuts and staff cuts. There's been a loss of expertise and specialized knowledge has been diminished. The Centers for Disease Control and Prevention, which does a lot of prevention work, a lot of overdose prevention work, so primary prevention as well as overdose prevention, they have had funding cuts and a lot of personnel cuts, as well as some data reductions. There's been slowed federal grants and a shifting of federal investments and policies away from what we've seen over the last several years. So let me get into some specifics about the structural changes, then I'll go into funding and finally executive orders and policy changes. So first, structural changes. The Substance Abuse and Mental Health Services Administration, I know all of you are familiar with this agency. It's the primary agency in the federal government that oversees grant making. The majority of grants that do come out of and are administered by the Substance Abuse and Mental Health Services Administration. About 50% of employees in this agency have left. And there have been wholesale reductions of basically lines of work. So legislative affairs staff have been eliminated. The National Survey on Drug Use and Health staff, the staff internal to SAMHSA, those workers were terminated. The Division of Primary Prevention, technical assistants, you can see them here. Mental health promotion branch. So again, these are more than just individuals. They are people who have worked on these issues for a number of years, who have built up expertise over time that is now missing at SAMHSA. The Centers for Disease Control and Prevention, which has a broader remit than SAMHSA does, they've also about over a third of their employees have left. And there have been several reductions in force over time. CDC's Washington, D.C. office was eliminated, as was the National Center for Injury Prevention, the policy and communications staff. They are important because they help develop new policies, and then communications for prevention is critically important. That staff has also been eliminated. Now, I want to talk about, I'm sure several of you have heard about the Great American Recovery Initiative. This was announced earlier this year. And Kathy Burgum, who was the former First Lady of North Dakota, who is Doug Burgum, he is the Interior Secretary. His wife, who is a person in long-term recovery, who's very committed to this issue, she and RFK Jr. are in charge of the Great American Recovery Initiative. If you read this fact sheet about the Great American Recovery Initiative, it has a pretty broad area of responsibility. It is very similar to the Office of National Drug Control Policy's lines of authority, in that the purpose of the Great American Recovery Initiative is to coordinate across agencies. there is very little more important on the policy space than integrating policies, because we know how important recovery supports are, housing, employment. And those are not overseen by just one agency in the federal government. And the federal government really is a behemoth. And so it is important to have that coordination. Now, the question right now, and I'll talk about this at the end, is with that broad remit, what is the certainly the intent is clear. What is the implementation going to look like? Just last week, RFK Jr., Secretary Kennedy, and Kathy Burgum visited Michigan, and they announced a number of grants. Now, the grants were under the rubric of the Great American Recovery Initiative, but those were grants that had been previously approved by Congress. And I'm going to get into federal funding right now. So the process of funding, obviously, in the federal government requires that Congress has the power of the purse. They have to come up with the appropriations. So the Great American Recovery Initiative in and of itself doesn't have specific funding unless Congress gives it to them. So I'm going to talk about those funding initiatives right now. As we look at there are several triggers here, all of which cascade fiscal pressure onto states. I'm going to start with federal Medicaid cuts. In the One Big Beautiful Bill, which passed last year, a very important provision in that act included worker requirements or community engagement requirements for individuals who live in Medicaid expansion states. So if you're 18 to 64 years old, you need to to demonstrate some type of community engagement in order to qualify for Medicaid. And those the requirements, you have to basically certify every 6 months that you're either working 80 hours or you're 80 hours a month, or you're involved in some kind of volunteer activity. I'm going to talk about a new rule that just came out that describes that. But the Medicaid cuts are one way, they're kind of the first domino to fall. We spent a lot of time over the last 15 years making sure that substance use disorder addiction funding was included in long-term funding programs like Medicaid. So you didn't have to just rely on appropriations every 2 years. But these cuts to Medicaid will impact disproportionately people who have a substance use disorder. And again, I'll talk about the rule in a minute. Then the second domino to fall are the state opioid response grants and SAMHSA funds generally, the block grants. Now, Congress has level funded state opioid response grants and the block grants. However, the president's FY26 and FY27 budgets called for reducing that. Then what happens when the federal budgets fall? That the states have to be, next in line. And so state budgets are also not doing great. They have to have, states, as you know, have to have balanced budgets. They can't print money. So they can't pick up all of any budget cuts that come, which will impact them because of Medicaid cuts. And then finally, the final domino here is really the opioid litigation funds. They're seen in many states as kind of the last resort. Several states have laws that say that if there's a budget cut at the state level, you can't just use opioid litigation funds to plug that hole. But all of these funding pressures redound to the services that will be received at the state level. And the local community level. So here I want to get a little bit more into the coverage gap that will exist because of these Medicaid cuts. So the Congressional Budget Office, which is an office in that is within Congress, estimates that almost 12 million people will lose Medicaid coverage because of these worker or community engagement requirements. And about 1.6 million people with substance use disorder will lose Medicaid coverage. Now, I want to say that we know from research how important employment is to people to sustain their recovery. No one is saying that people should not work. However, the majority of people who do receive Medicaid coverage already work. The cuts happen because of the paperwork requirements, or people may just not know that they have to certify every 6 months. So that gets into what the requirements are. So again, every 6 months, you have to recertify your eligibility. There's a medically frail exception. Just the fact that you have a substance use disorder alone doesn't determine whether or not you can get that exception to the work requirement. States are going to have to require more information in order to determine whether or not someone can still work. And that doesn't just apply to substance use disorder, that applies to other chronic conditions like cancer. There is a treatment exception, and it's defined here, a drug addiction or alcohol treatment and program. And finally, if you are incarcerated, you are exempt from the work requirement. So what I want to talk about now are the executive orders and a few policy changes. There have been, as you well know, several executive orders that have been issued over the last year and a half. The first one I want to talk about was issued last year about this time, Ending Crime and Disorder on America's Streets. This executive order was really intended to address the narrative about social disorder. So public drug use, open air drug use, people living in encampments. A lot of what you saw over the last few years during the campaign, that was the intent of this this executive order. It did, in the executive order, targeted primarily mental health conditions, but for substance use disorder, it sent a message about we are not going to spend money on harm reduction. And it also sent a message about that cities and states that do more to get people off the street will receive more funding. So this was kind of a messaging document that was intended to guide funding by federal agencies. Shortly after this executive order was issued, this Dear Colleague letter came out from the Substance Abuse and Mental Health Services Administration. It was signed at the time by the highest ranking political appointee at SAMHSA. And it said a couple things that were very important. First of all, it said, look, naloxone is not harm reduction, and federal funding can still be spent on naloxone and other overdose medications. The purpose of it was to be sent out to states so that they knew what they could spend, what the parameters are, what the guidelines were, how they could operate under the executive order. It also said at the time that test strips are allowed. So xylazine and fentanyl test strips would be allowed for funding. July of 2025. So then fast forward to April of 2026, this new Dear Colleague letter came out. And it was much stricter than the July Dear Colleague letter. So basically, the July 2025 Dear Colleague letter was pretty much preempted by this April 26 Dear Colleague letter. And what does it say? It went into greater detail. No HHS funding could be used for syringes used to inject illicit drugs. No federal funds, HHS funding, could be used for pipes or safe smoking kits. And no federal funds could be used for test kits intended for use by people using drugs. No HHS funding could be used to support overdose hotlines or to distribute sterile water. And finally, no HHS funding could be used to purchase or distribute, and that's the key word here, or distribute any other drug paraphernalia or supplies that promote or facilitate drug use. There's a couple really important pieces about this. First of all, in 2015, when I was in the Obama administration, we negotiated language that's been in the appropriations reports since that time. So for over a decade, language has been in appropriations reports that say you cannot use HHS funds to purchase syringes. It doesn't say anything about using those funds to distribute syringes. So this does mark a break, and one could argue that it conflicts with the HHS appropriations language. But the HHS appropriations language doesn't say specifically that you can use federal funding to distribute. So there could be an argument there that this does not conflict with congressional appropriations language. It's also important to note that no federal funds currently can be spent on pipes for safe smoking kits. That's against federal law. The other important piece, though, is the fentanyl test strip, xylazine test strips. That was allowed beginning in 2021. So this marks a break with that past language. However, it does allow federal funds to be spent on larger equipment that is often used by public health departments to identify drug trends. They're mass spectrometers that can identify different substances, including fentanyl and xylazine. So this has sent, this recent Dear Colleague letter has caused a lot of consternation in the field, understandably, because many harm reduction programs are underfunded to begin with. And if you have to find funding to come up with funding to plug that hole, that's for someone who might be distributing syringes, that's a pretty big hit for harm reduction programs, syringe services programs, which, as we know, don't promote substance use. Syringe services programs have been proven to decrease bloodborne disease, including HIV and Hep C. This is really a marked different direction than had been taken in the past. So now I want to talk about FY27, so fiscal year 2027, that begins in October. On October 1 of this year is when the new fiscal year begins. And I want to shout out our intern, Wallace, who helped come up with this information for us. So the president's fiscal year 27 budget basically called, just like the fiscal year 26 budget, the president sends his budget to the Hill every year. Congress, again, has the power of the purse. Congress doesn't need to go accept what the president sends. And in this case, this is just the House, what the House has done so far. The president's budget called for an elimination of SAMHSA. It didn't call for eliminating the purpose of SAMHSA, but it called for combining SAMHSA with a number of other federal agencies at HHS, HRSA, and a few others into what they're calling the Administration for a Healthy America, or AHA. And it did reduce SAMHSA's budget. Now, the argument they would say is we didn't really reduce SAMHSA's budget, that because we combined it, it saved money. But Congress so far in the House has said, no, you have to go through another process if you want to reorganize HHS. And so they have not accepted this reorg so far. The Senate still has to come up with their numbers, but so far House has not accepted it. The state opioid response grant, which was first appropriated in and went out to states in 2017, there was a proposal by the president to consolidate that. House, again, so far has said no, and their mark is $1.6 billion, which again is level funding. It's what it's been for the last couple of years. Substance use prevention, there was a call to decrease that in the president's budget. The House has kept it level. Substance use treatment, an increase. Again, that is a number of different programs. And then finally, the 988 Lifeline, that's a federal funding source that's been in place for the last couple of years. That goes to states, and that's been increased. A few other important pieces here. So tribal behavioral health grants, the House is agreeing to fund that at $30 million. Drug-free communities programs are prevention programs that are in every state in the country. They are administered by the Centers for Disease Control and Prevention, but that funding goes through the Office of National Drug Control Policy. The president's budget called for reducing that by about $30 million. The House said no so far. And then a couple other important pieces here. The National Institute on Drug Abuse is the largest research institution in the world. The president proposed consolidating it, making it into the National Institute of Substance Use and Addiction Research. So combining NIAAA, alcohol abuse and alcoholism, with drug abuse. And it would have reduced it some. Congress has so far in the House has said no. Now, this has been tried in the past, and there's some total logic behind why one might want to consolidate research on drugs and alcohol. In the past, when that was tried, actually the alcohol industry opposed it. I don't think this is going anywhere, but that was the president's proposal, which has so far been rejected by the House. So there are four immediate things I want to talk to you about now. First of all, the CMS Medicaid rule. Now, as I mentioned before, the One Big Beautiful Bill or Act, since it's been passed, it did call for a change in the work requirements. Now, work requirements have only been in place in a couple states, Arkansas and Georgia. Arkansas did implement it for a while, and actually it didn't save Arkansas any money. And again, the majority of people who lost Medicaid eligibility, it wasn't because they weren't working, it was because of paperwork problems. So this new Medicaid rule that just came out on June 1, they are accepting comments. The comments are due July 31st. And anyone can comment on this. And I have a link in the slides that I think you'll get. And you can write your response to this. It's a fairly complicated rule, but the Administrative Procedures Act requires that the agency who is issuing a rule review every single rule. Now, they're now doing this by AI, but it is important that people make their voice heard about how the Medicaid rule might impact them or people that you work with. The second rule I wanted to bring to your attention is the Office of Management and Budget rule. This rule is, again, very complicated. However, what it will do is revise how the approval process for grants and research. Researchers are very concerned about this because it puts a lot of restrictions on researchers on the type of work that they can do. It puts a lot of restrictions on funding, but most importantly, it puts it would put a political sheen on basically every piece of research funding that goes out from the federal government and every grant. Now, I was a political appointee for 9 years, and first of all, it's asking a lot because there's a lot of grants that go out. There's a lot of research that is approved, and this is a very disturbing rule. And I put again the link in here. Comments are due July 13th, and it's important that everyone's voice be heard on this. The CMS Medicaid rule, the Legal Action Center has some nice materials on this. Office Management and Budget, I know that that Ryan Hampton's group has just put out some information about this. So that's another important rule. The Great American Recovery Initiative has just put out a request for information. Those comments are due in 2 weeks. This request for information is basically asking the public to say what works, what doesn't, and what research do you have to back it up. I don't think there's anything wrong with asking that. And perhaps I'm biased, but the Office of National Drug Control Policy is tasked by Congress with putting out a national agenda and a national strategy. That strategy includes research and evidence and is very robust. And actually, I don't have a problem with what was put out by the Office of National Drug Control Policy this year. It has a lot of research. It talks about prevention, treatment, recovery. It leaves out harm reduction, but prevention, treatment, recovery, all very important pieces of the public health issue. So for the request for information, I would refer them to their own Office of National Drug Control Policy drug strategy, which would inform the work that I believe that they could do as a federal government. And then finally, FY27 budget. And if you haven't been, in touch with your member of Congress, I would recommend that you do so in the House and the Senate. And basically the message to send is, informing them about the importance of continued federal funding for all of these projects and programs. And to the extent that, you can talk about how it personally affects you, the people that you work with, that really does make a difference to members of Congress. So I want to leave, right now we're really talking about how to kind of keep our fingers in the dike to control, to sustain the progress that we've made. But I do think it's important that we think about what should it look like? What should addiction policy look like? And how can we build that kind of system in the future that does provide evidence-based prevention, treatment, harm reduction, recovery supports, that has that entire continuum of care for people. so that we don't have to reinvent the wheel every 4 years or even every 2 years and, trying to figure out what works and what doesn't. We should really be thinking about what we want it to look like in 10 years and how can we make sure that the people who go behind us aren't dealing with the same issues that many of us have dealt with in the past. So with that, I thank you. This is my contact information, and I do a regular Substack where I do updates on these types of things. So feel free to sign up for updates. Thank you.
Oh, thank you, Regina. I think we will send those. We're going to send the video and you'll be able to get the links off of the video, or maybe I'll just send them with the video so you have the actual links that you can go on for the to send information. Who did you say for the CMS Medicaid rule? Who did you say has information on that?
Legal Action Center.
Legal Action Center. That's right. Okay. All right. That was helpful. Just to have someone that has some information, because we can write, I think if we can write something that has some research behind it, that's great.
Yeah.
Does anyone have any questions they'd like to put in the Q&A? Oops, I see some questions coming up here. Can you see them at all?
Yep. One was, can you put the links in the chat? And it'll come to you, and then
Right.
no other questions.
No other questions. Anyone have anything else they'd like to ask? There's a lot of information. And we did have to wait till very last minute to get the slides because everything keeps changing. So I do think there were some positive things in there. I mean, I think, it's easy to look at everything going on and get panicked. And
Right.
so I appreciate when we can do some, give some positive information as well.
There was one person, Teresa, who said she had a question.
Okay. Where's she? Oh. Can you write it in there, or do you want to, let me see if I can just let you speak. Let's see, Teresa.
Oh,
Oh,
Rocky Schwartz had a question.
Oh, here's Teresa. Okay.
Okay.
Are there any efforts to coordinate with COCs? COCs. Let me see. Let me just get you to, I'm going to let you speak, Teresa. Let me get you. Okay. Okay, go ahead, Teresa. Oops. Can you unmute? Right, we'll come back. Let's go to Rocky.
Yeah, he asked about the visit last week in Michigan, and I thought I read they visited Christian-based only. So interestingly, and I want to credit my colleague Andrew Kessler, who looked this up. If you look at the actual grant they're talking about, they talked a lot about faith-based. We all know that it's been long-standing policy to support faith-based programs that are evidence-based, long-standing policy. The visit last week, I don't know if they only focused on one denomination, but the underlying grant did not say it was open. It wasn't open actually to nonprofits. It was open only to state and local governments. So I think, again, you rely on people like me or others who are lawyers and will read the fine print. And you have a lot of people that you rely on who read that fine print. So I think a lot of it was messaging rather than what the actual grant said. Because again, they couldn't come up with a new grant. It had to be repackaging a grant that had already been appropriated by Congress. So I don't think it was secular only, but there's a big emphasis on faith-based programs, which has been a long-standing tradition. Perhaps it's not talked about in the way that they have, but it's pretty long-standing policy.
All right. I'm going to try Teresa again. Can you? Uh,
Okay,
stuff.
I got it.
Ah, there you go.
Uh, Thank you for having me. I just wanted to mention with all of this work, and it is a lot, especially with all these changes, I'm thinking along the lines, and then give me your thoughts. And maybe they'll have to wait till later to think about it. But um, I'm involved with the continuum of care from the county. I also serve on the advisory board, state advisory board, right? And where I'm going with this, and I said this in the COC, we have far too many people that deal with substance usage, harm reduction, and all of the stuff that we're fighting to keep that are affecting the whole work requirement and all of these things, right? That we need to at least have representatives that are coming in the spaces, and we could do um, a more impactful sign on letter. I'm not discrediting anything we're doing, but more voices, more people, more power. That's where I'm going with this. And I've mentioned it in the Essex CLC. I brought it before the State Advisory Board. And Tonya, I may not be able to be in your meetings as much, but even to the businesses with harm reduction and what that looks like. And there's so many other residual points that are equally as important that maybe if we can condense is not the right word, but bring a few of the points that can touch within varied spaces. I hear what you're saying about the faith based. I'm also a licensed minister, so what I'm going to put out about that is in those grants, the missionary ministries and things like that, and I think it becomes more of service information awareness of what can be done and some of the options based on what we know and how we can present this to the faith-based communities. I'm thinking Faith in Action. Now that Dr. Van Zandt and the other young lady, she's been there for a while when it was the interfaith group. But the reason I'm thinking about that, he sits in another space of more of a larger faith-based community in a higher standing, and if we can um, maybe give an overview of what that could look like. Because sometimes when monies or the emphasis is put upon us very strongly, we want to do something, but we're not sure what the best something is. So we do anything falling short. Whereas if we had some uh, points, like of how we can be more effective. You know what I mean? Is that making
Mhm.
sense?
Yep. So I just sent Tanya the Legal Action Center information that she can send out because I'm work in an academic institution. Um, I can't advocate, but I can educate. So we rely on others to do the advocacy piece. And as I mentioned, Mobilized Recovery is doing something on the OMB rule. Legal Action Center is doing it on the Medicaid piece. And the Medicaid rule, that's the legal, I trust Legal Action Center to give you, like, here's what the information is. So I sent that, and I'm sure that will go out to you.
As a point of reference, if I could say, I sit as a National Leadership Council for the NSBA, and I have been pushing because there is so little uh, informational awareness about what's
Mhm.
happening and the impact that it's going to have for them to ask them on a larger scale. We go back to this in September on the fly in. but to ask them to be able to certify, because people are going to get dropped from the roles that are already working because we don't have a consistent way that stands for people to be able to verify that
Yep.
they're working. I mean, there's so many steps to it that
But
they're bound
there's,
to get
yeah.
lost.
Yeah, there's this the state has been trying to do a lot, like prepare, right? Because we know this is happening and they're already preparing on how, and the thing is everything keeps changing, right? So they come up with a plan on how to prepare for that, and
Yeah.
try to get on top of it, and then they have to keep changing. So the state is really working on how that's going to happen. And as
Aware.
advocates, we're all like we're going out, and it's like we've got recovery centers and harm reduction centers and treatment programs, and we're all trying to get everyone on top of it as well to try
Hmm.
to, stay in touch with people we know who are on Medicaid and who need, who need to be on
I'm
top.
very aware, and I applaud everybody. I sent, I think it's a 3-page bullet point on how to
Right.
weave the thread. But and so I applaud New Jersey. But when I look at our neighboring states, and to get this out, because we have people that work in PA, we
Hmm.
have people that work in New York that are going to be affected outside of us. So
Right.
Yeah,
just
it's definitely something we all need to look at for sure.
Yeah.
Um, all right, I'm gonna move on. Let me get on to Brian had a question. Are there example letters to start with to focus on the so I think we kind of mentioned that a little bit, and I think these links that we're going to send you will have some samples probably. I
Yeah.
think
The Legal Action Center one that I sent you does.
that okay, and I'm sure Mobilize will, and I think
Yeah.
Chad's on here. I think Chad Saboro is probably doing some things as well.
Yeah.
So I think,
Yeah. He has a good breakdown.
right, Chad's got a lot of information. So I think
Yeah.
look into Chad's information, his Substack, your Substack. We're very, these Substacks have been great. There's a lot of
Yeah. Well,
information on them.
there's a low barrier to entry, so
Right.
I don't have to wait a week for someone to say if they're going to print it or not.
Exactly. Exactly.
Um, One of the questions was about the RFI, what safeguards and protections are in place for those that respond to offset the distrust with the current administration. You can do it anonymously. And if you are, very vigilant and are concerned about an email going, they take other ways too, and there are some other anonymous emails, but you can do it anonymously.
Sad that we have to think that way, but we absolutely have to, I guess. I thought I saw someone
Yeah,
else.
one of the others was the take on the new guidelines coming out with the SAMHSA notice of funding opportunities regarding the first 60 applicants submitted will be received. The opportunity will close. Yeah, what happens to the money? So, first of all, I mean, Congress needs to, they fund these programs. If there are games that are being played, Congress needs to say, there's oversight committees. Again, I'm not sure that'll happen this year, but perhaps in the future. The question, though, about what happens to the money, this is getting into the weeds. There's no year money, which means that it can be spent in the future, and there's only for this fiscal year money. So it goes away if it's not spent. And this is another way to cut, that the Office of Management Budget has, or the budget folks in the agencies have, of trying to cut funding in lieu of doing the Doge work that was done originally. There are all sorts of creative ways to cut spending, and in some cases, that money would go away if it's not funding that if it's only for that fiscal year. So it depends on the grant.
Was that Ken that asked that question? I know one of these.
Nicole.
Oh, okay. I think, oh, Nicole. Okay. So I think, do we have someone chat that where I'm missing it? I don't see anything else in the question and answers. Do we? Let's see. Oh, yeah, that was on chat. That's why. All right. Do we have anyone else? We've got a few more minutes. Okay. So in these, so the first thing that's up is the RFI, right? That's the one that's due first,
Right, that's due first.
right? And the others are all the 31st.
Yeah.
Right.
13th and 31st.
Okay.
Yeah.
Okay. All right.
And
So,
the link to do that is I provided the link. I sent you separately the Legal Action Center link. And I don't have a link for Mobilize, but I know that if you're on
we
Mobilize
work with
recovery
them all
list,
yeah, we work with them all the
he's
time.
just sent something out.
Okay. All right, that's good. I'll check on that. We'll get that link. So we'll get all those links to everyone with the copy of the webinar.
Just another question.
Okay.
What measures can we take to prevent the opioid settlement funds from using just shore up program budget cuts elsewhere? Good question. This is complicated. There are many states that have that you can't anti-supplantation legislation. So if you used to spend money on X and or the legislature chooses not to and they want to supplant it, in many states you can't do that. It has to be new funding for new things. So the best way to shore that up, to make sure that the opioid litigation funding is going to for new things, is by having the anti-supplantation language. I think New Jersey does, but don't quote me on that because I'm not sure. I think that's been well received in a lot of states because a lot of people see the opioid litigation settlement money as this big piggy bank that they can raid if they don't want to fund something else. And that's going to people have to be really vigilant. The other way to make sure to prevent it is by making sure that the state, and again, I think New Jersey's doing a good job of this, that you have visibility on where the money's going. That there's transparency, because there are a lot of states where the money goes into this black hole and you really don't know, especially for local funding. In states where the local governments get like 50% of the funding, it's really hard to know where that money's coming from, where that money's going to, rather. So transparency and that anti-supplantation language are the two best ways to ensure that.
And if anybody here is not aware, we have a group that we put together, the opioid advocacy group, the OSAC, Opioid Settlement Advocacy Group in New Jersey. And the reason is exactly what you were saying, is that the money is split. And so half of the money in the state goes to the county municipalities. And, we only see a report on where that money goes or what's spent every year. So we don't know what's going on through a whole year, and we've been going through it and just kind of picking through it. And there's definitely we have had a raid in the money. We did do that and we fought back. We have legislation right now for, to put money, to fund someone, that we're, also thinking this is not the way you're supposed to do it. So we're pushing back on that. So we do have advocacy groups and if anyone's interested, they can contact me and I'll connect you. We meet once a month and you can get involved. Great. And the other part of this is that we're also trying to take good programs and spread the word.
Mm-hmm.
Because there are municipalities and counties doing really good work with that funding. And we want to be able to give that opportunity to other counties and municipalities and connect them. So I think that's really important. Good. Yeah. So yeah, I guess we the budget cuts, it's going to be an issue. We know that's going to be an issue. We already have seen that's exactly what's going on right now with legislation. We have a group that was funded by the Department of Justice and they dropped, they're not funding them. And so they went to a legislator to write legislation to get the funding. And I think it's just advocacy at this point.
Right. And I see what you're saying, Brian, in the Q&A about sometimes if the feds aren't doing it anymore, you may just have to do it. And that it's just like, how do you make the fact that that's an intentional decision to make, and hopefully it won't be forever, like that doesn't end up lasting for the next 5 years, that you are able to continue. But I do think it's important that you distinguish when you just have to fund it, because otherwise it's not going to happen. I mean, there's probably a lot of syringe services programs that are going to close if they don't get some type of funding.
Right. And I think we have to look at it case by case, right? But I think there's a process that we have in place, and we have to make sure we go through that process. Legislating money, it will be gone as soon, because everyone's going to go to the legislators. They're going to
Right.
write for funding, and things change. Nothing should last for the lifetime of the funds.
Mm-hmm. Right.
We need to be able to change things up. So, yeah, it's a lot of advocacy. It's a lot of work, a lot of frustration. But there's some good things too. I mean,
Yep.
we really can get some good things going with this money.
Right. Right. And at this time, it's the only long-term source of funding that
Right.
you're going to get.
Thank you so much for this information. It was really helpful. And I'm
Thank you.
really honored to have you.
Yeah, my pleasure. Thanks.